Welcome to this presentation of new interRAI research published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson from Doctors Manitoba, and I'll be your moderator. The session will include 3 interRAI researchers who collaborated on a paper entitled The Forensic Supplement to the interRAI Mental Health Assessment Instrument, Evaluation and Validation of the Problem Behavior Scale. We'll begin with a brief presentation by interRAI Fellow, Dr. Howard Barbaree. Dr. Barbaree is a forensic psychologist and professor in the Law and Mental Health program in the Department of Psychiatry at the University of Toronto in Canada. He is an associate fellow of interRAI, a member of interRAI's network of mental health, and is actively involved in the development of the forensic supplement to the interRAI mental health instrument. He will be joined by 2 of the authors from this publication, Dr. Krista Mathias and Dr. Brant. Dr. Mathias is an interRAI fellow based in Saskatoon, Saskatchewan. She's a member of the interRAI network I mentioned before and serves on the forensics subcommittee. Dr. Mathias was involved in the development of the mental health clinical assessment protocols, or CAPS, and is actively involved in the development and research of the forensic supplement to the interRAI mental health instrument. Dr. Fries is a founder and president of interRAI and an emeritus professor of health management and policy at the University of Michigan. He has co-authored assessment systems for nursing home residents, home care recipients, persons with disabilities, prisoners in corrections facilities, and caregivers. In his research, he works with U.S. states and international governments to develop better decision-making from the clinical to the policy levels. We will provide a web link to the article in the special issue at the end of today's webinar. But in the meantime, I'd like to turn things over to Howard to begin your presentation.
So thanks, Keir, for the opportunity to present on our research on the forensic supplement. A large worldwide survey of psychiatric inpatient programs investigated the significance of various threats to patient safety in inpatient psychiatry. The kinds of threats they considered were medication errors and falls. Of all the potential threats, the top 2 by far were interpersonal violence committed by patients and coercive interventions by staff. When inpatients become violent, staff are obligated to prevent further violence using coercive interventions, namely physical restraints or seclusion. So, how big a problem is this? A meta-analysis of the world's literature on the prevalence of violence among psychiatric inpatients estimated that approximately 1 in 3 psychiatric inpatients had been violent at least once while in hospital. They report that prevalence is much higher among forensic patients, approximately 1 in 2, and that compares with acute care patients, 1 in 4, or general psychiatric patients, 1 in 5. These differences were even more significant when they compared incidence rates. Forensic units had an incident rate per 100 admissions of 406, while rates on acute care units and general psychiatric units were much lower, less than 50. Therefore, it would be important to assess patients' risk for violence at admission to hospital, especially in forensic programs. Numerous validation studies support the use of the interRAI mental health assessment systems for inpatient mental health assessment, triage, treatment planning, and outcome measurement. However, there have been suggestions that the interRAI-MH does not include sufficient content relevant to forensic mental health. While the interRAI-MH has plenty of content regarding interpersonal violence, and information contained in the instrument has been shown to predict violence, see the risk of harm to others CAP, it does not include enough information regarding the factors that lead to or predict violence in a forensic setting. We address this potential deficiency through the development of a forensic supplement to the interRAI-MH. Using prominent forensic risk assessment instruments, we identified forensic item content domains that were missing in the interRAI-MH. We then independently developed items to provide appropriate forensic coverage. The resulting forensic supplement is a single-page, 19-item document that can be scored along with the interRAI, adding approximately 10 to 15 minutes of administration time. Then we constructed the Problem Behavior Scale, or PBS, using 11 items from the interRAI and forensic supplement based on an examination of the intercorrelation matrix. Our intent was to construct a scale that would help clinicians identify inpatients at admission that were at high risk for violence and need for coercive intervention. We tested the validity of the PBS using 4 samples. The developmental sample comprised forensic mental health inpatients from 2 large mental health specialty hospitals who'd been assessed with both the interRAI and FS forensic supplement. The first validation sample was an independent forensic sample. The second was a random sample of inmates in prisons, and the third was a group of youth in police custody. In the independent sample, we used binary logistic regression to demonstrate that the PBS predicted 3 negative patient experiences: recent verbal abuse, use of the seclusion room, and failure to attain an unaccompanied leave. For each of these 3 validation samples, we conducted the same statistical analysis. In the validation forensic sample, the results were replicated exactly, with the addition that the PBS predicted the use of restraints. In the correlational sample, the correctional sample, the PBS predicted solitary confinement and the use of restraints. In the youth custody environment, they don't allow coercive interventions, but the PBS predicted resistance to care in various forms. Finally, we examined the relationship between PBS scores and care planning triggers, part of the interRAI system of clinical assessment protocols. In all 3 validity samples, the PBS was significantly related to the following CAPs being triggered: harm to others, interpersonal conflict, traumatic life events, and control interventions. In conclusion, the PBS is a good predictor of the use of coercive interventions by staff in forensic hospital and other forensic settings. Moreover, the pattern of findings was amazingly consistent across quite different forensic settings. We conclude that these validations generalize our findings across age groups, adult and youth, and across healthcare and correctional settings. We also conclude that the PBS, in conjunction with the interRAI CAPs, can provide additional information to promote and inform care planning for this difficult hospital population. This latter finding provides clinical teams with the wherewithal to potentially prevent violence among inpatients and the need for coercive interventions. Thank you for your attention.
Thank you very much for that presentation, Howard. I'd like to start with a few questions for you as the lead researcher. And I wonder if you could take a moment to describe why it's important to reduce the use of coercive control techniques in this setting, and how this risk framework could prevent the inappropriate use of these interventions in an inpatient psychiatric environment.
So the problem with coercive interventions is that they are dangerous. People die in restraints. Restraints restrict the patient's motion. They develop an embolism, and the embolism travels to the lungs or to the heart and cause very serious problems, including death. It's estimated that in the US, there are between 50 and 150 psychiatric inpatients die every year. In my 30 years involved in inpatient psychiatric care, I've known 3 patients who've died in restraints. And the process of putting people in restraints or putting them in seclusion is a violent episode which has harmful effects on the patient as well as staff. And seclusion also has terrible effects psychologically, very similar to the psychological effects of solitary confinement. The other issue is that staff who have to effect these restraints are frequently injured in the process, leading to long-term disability and labor issues for the hospital. Our framework seeks to identify high-risk patients within hours of admission to hospital and assign them immediately to receive interventions that work to reduce their risk for violence. Hence the importance of the relation between the CPS and the interRAI caps.
Thanks for that. I wonder if we could talk a little bit more about the advantages of using the interRAI assessments and the problem behavior scale in the forensic mental health setting over what the usual practices might have been. You've touched on some of that, but if you could go a little deeper.
Sure. Usual forensic practice uses traditional risk assessments, usually conducted by highly trained psychologists or psychiatrists. They're not just certified in their profession, but they're further trained in forensic, and then they're further trained in the use of these instruments. Most often when these experts are doing their assessments, they're preparing a report and or testimony for presentation to a court or review board or parole board, where the liberty interests of a patient are in question. The expectation is that after they present their findings, that they'll be vigorously cross-examined, and their reputations all the while are at stake. Given the care and attention to detail required, my experience is that the results of these risk assessments are ready for use on the front lines of care months after admission to hospital. Now, the advantage of the PBS is that it can be done as part of the initial RAI-MH assessment, which means that the front lines of care will have the results usually within 3 days. It's important to say that the PBS is in no way a replacement of traditional risk assessment instruments. If the PBS is administered admission to hospital and every 3 months thereafter, the results can inform clinical care designed to reduce violence. And later traditional risk assessment results can be used to corroborate PBS results and then refine the treatment plan if required. Each of these two kinds of assessments have their place in a forensic unit.
Thanks. My time with interRAI began working with the home care and nursing home tools. And certainly I know clinicians, as they were being introduced to the tools, that was the concern about what they'd been using, the alternative tools or scales or assessments they'd been using for years, and how they would adopt and integrate a new tool into the practice. So it sounds to me that what you're saying is in this setting, the PBS, the behavior scale, should and can be used in relation to other assessments they're using, recognizing that they may have different purposes and uses for their work.
That's correct. There's a certain amount of resistance to the use of the PBS, I think, in a forensic setting. There will be, and it's up to us, I think, to work towards acceptance and showing people how these data can be used.
Right. Thanks for that. I'd like to bring one of your co-authors into the discussion, if I could, Dr. Brant. Of course, somebody who has a long history with interRAI. Brant, of course, the original focus of interRAI's tools in the early 90s was on older adults and long-term care. And I wonder if you could talk a little bit about where did things go from there? Why and how did interRAI expand to more diverse care settings and populations?
Well, it's actually interesting. It started in 1999. Ontario Ministry of Health reached out to John Hirdes, who's the editor of this whole volume, and they asked whether or not we could extend what we were doing in the aging environment to the mental health. At that time, interRAI was really organized around assessments for aging individuals, was primarily nursing homes and home care settings. And so the question was, could INTRAI do it? Should we do it? So for background, I'm a methodologist. I have a doctorate in applied mathematics. So I believe that I could develop assessments in any setting as long as I had collaboration with experts in that setting. And that's what we found was really possible. So we were able to develop that instrument. And in the end, it helped INTRAI in some very interesting ways. First of all, it showed that we could do this, that if we could get the right types of experts together with the experts, when I say experts, experts in the application field, together with experts around measurement theory and statistics and so forth, that we could do it. It led to a network around mental health that John Hirdes now shepherds. But the mental health content also improved all of our instruments. So we found better ways to measure things, better ways to measure psychiatric symptoms, scales such as the one we're talking about here that could apply to other instruments. And therefore, it improved those instruments. But probably the most important thing was that it was a start to our realizing that we could develop a suite of comprehensive interactive assessments that covered all the healthcare fields. Because people move between settings. A person with a mental health problem can end up being in a nursing home with the mental health problem. And therefore, it's really important to be able to follow them with coordinated instruments so as they move between settings, you continue to have the same sorts of measures. And this research helps in that context, in that it is a scale that we think is going to be useful across multiple different types of settings.
Thanks. That's, I think, one of the things that I've always been so impressed with interRAI is there's a core approach, the secret sauce, although I suppose it's not so secret given that you publish it in peer-reviewed publications for all the world to see, but that special sauce that you don't impose on different settings of care as you go in. You look for people with relevant subject matter expertise with to ensure that these things are adapted and adopted in a way that makes sense for each setting as well. And I've been fascinated to see that expand and grow over the last couple of decades. Now, when it comes to the criminal justice system, this has been a key area of focus for interRAI, I understand, over the last decade. And you led work related to mental health in correctional settings. Could you describe for us what your findings from that work found?
Well, I wasn't the only one working in this setting, and Howard was involved with it, and other of our colleagues. But at least for me, this was a study that was required by the state of Michigan to review the Michigan Department of Corrections prisons, correctional facilities, and to look at what psychiatric problems the prisoners had and the psychiatric care that was provided to them. And so in this study, which is a while back, we used the interRAI mental health instrument. We did some adaptations to be used in a prison setting. And in fact, some of that actually ended up as part of the forensic supplement that Howard Barbaree just talked about. We use the instrument as a survey instrument. That's not the way we usually use our instruments. Usually our instruments are used as part of the clinical care that we're providing people, and therefore leads to actions in their care and not just as a survey. But it did give us a very good way to understand the problems that prisoners had, mental health problems that prisoners had. We did a representative sample of 618 prisoners in 24 Michigan prisons. We determined severe mental illness using scientifically derived scales, the cognitive performance scale, depression rating scale, positive symptom scale, a negative symptom scale, and a mania scale. We agreed with state experts on the definition of what was severe mental illness, and the results were a little disturbing. 20% of the prisoners had mental health symptoms. 17% were getting services. That by itself doesn't sound too bad, but the problem was there was very little overlap between the two groups. So of those people who had mental health symptoms, only 35% of those prisoners were actually getting services. and perhaps even more disturbingly, is it wasn't related to severity that they had. It wasn't as if the 35% were all those that were the worst. They were rather equally distributed across the range of different symptoms that they had. Even if it was possible to increase mental health services in the prison population, Michigan had to target it better. It had to make sure that it was providing services to those that were the most severe. The interRAI mental health instrument could do that, and that was what we suggested. Unfortunately, as often happens, I'm not sure that many changes have been made. The data, however, that came out of the study was used for validation in the study that we're just talking about here, and Howard addressed that.
So I'd like to bring in Krista Mathias, Dr. Krista Mathias, into this discussion, another author from the research. Krista, I wonder if you could help us understand how the interRAI mental health and the related supplements contribute to decision-making at that policy level.
Well, these instruments can inform staff training on early intervention and de-escalation strategies to help reduce the need of coercive approaches at the beginning of an episode of care. They can also result in reviews that can inform internal policy, which can inform practice, to identify ways to improve intervention strategies, support patient recovery, and ensure safety on the unit itself. These instruments or assessment instruments can inform decision-making and protocols. For example, decision-making around a person's readiness for unaccompanied leaves from hospital. These assessment instruments can also allow for health system performance comparisons that can be conducted with the development of quarterly benchmarking reporting systems. And they can also inform the development of mental health quality indicators.
Thanks. I appreciate that. Now, I also understand you're an expert in gender-based analysis. And of course, this is very important in many settings. And I wonder if you can talk about how gender affects mental health needs and outcomes in forensic psychiatry.
Sure. Women represent a smaller percentage of the population compared to men, and this is true both in prison and inpatient mental health settings. Despite this, women are more likely to receive psychiatric care for criminal behavior in comparison to men. Women have fewer criminal convictions and more lifetime psychiatric admissions. And although it's generally believed that women are less of a threat to society, so with respect to violent recidivism, so violent risk of reoffending, there is a general agreement that they present more of a challenge within a secure hospital setting. So this could suggest that they may be higher need than their male counterparts. As well, there are gender differences in how men and women express mental health symptoms. So for example, the physical symptoms around depression, as well as criminogenic risk. So things like psychopathy and aggression. So from my research, gender was shown to have separate and interacting effects on mental health and criminogenic needs. So understanding these differences in a forensic mental health setting can result in care that meets a person's needs, but is also sensitive to the social context.
Thank you very much. I wondered, and we could bring others into this discussion as well, how the forensic supplement has addressed previous information gaps in the interRAI assessment systems generally, and what settings can use that forensic supplement. Maybe I'll go to Dr. Fries first. I think you touched on this a little bit in one of your answers earlier, and then we can go to the others if they have anything to add.
Well, whenever we have content, we always look to see whether or not it works in other settings. Some of the measures that we have in the forensic setting had to be adjusted because of the look back period. So for example, you're asking something about drugs use. You're not going to ask that and say, did you have drug use in the last 2 years? Well, if they're 10 years in a prison, it's not a really good question to try and collect information on. Either they're going to be lying that they did have drugs, or they're admitting to breaking the regulations within the prison. So some of the items will not be useful in other instruments, but something like what we just talked about, the problem behavior scale, That's common across all of the instruments, and being able to show that the same measures and scales work across different instruments, and that the items potentially that support them are useful and effective, says that those items might well be in other instruments, even though we might have thought of them originally in a forensic setting.
Howard, do you have anything to add to that?
No, I think the problem behavior scale, for example, can be embedded in the other instruments. It has been the youth instrument that's used by Shannon has the problem behavior scale embedded in it. So no, I don't think there's very much of a problem, particularly with the problem behavior scale. There's some items on the forensic supplement apart from that don't quite fit in some settings, as Brant has said, but it means you have to make some adjustments in the wording of the items. That's all.
Okay. I wonder about the next step for research related to the forensic supplement, and Krista, if you wanted to maybe comment on that first.
Well, I think that we've done a lot of work with the forensic supplement in inpatient settings. I think it would be interesting to test it in community mental health settings. Of course, some of the elements of it might need to be adjusted again for this specific setting, but I think that would be an interesting avenue to pursue down the road.
Howard, last word to you. Anything on the next step for the research in this area?
I think the most important next step is to do a prospective study to see how well the prediction works from let's say the initial assessment to 3 months to 6 months and so on. Yeah, I think that's probably the most important issue for us to cover next.
Great, that's a good point. So with that, I would like to thank all three of you for taking the time to walk us through the research and answer some of the questions that our viewers might have. So thank you to Dr. Howard Barbaree, Dr. Brant Fries, and Dr. Krista Mathias. Your work is very interesting in this area and tons of potential. I think we can all agree. I look forward to following the developments in this area. And I'd like to thank all of you for watching this presentation on interRAI's research in mental health and addictions. If you'd like more information about this or any of our related work, please contact us at info@interrai.org. That's info@interrai.org.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at any time to view new presentations on this special issue as they are posted.